Welcome to RSNA 2024. This is Larry Tanenbaum, and I'd like to welcome all of you here to the Applied Radiology Roundtable series on the latest trends in Alzheimer's imaging and management. For this module, Preparing the Enterprise for the Growth in Alzheimer's Disease Imaging and Management, I'm joined here by Dr. Tammie Benzinger, who is a professor of radiology and the chief of MRI services at the Mallinckrodt Institute of Radiology. Welcome.
Thank you, Larry. Excited to be here.
Nice. And Mr. Saurabh Sharma, who works in MR business development for emerging markets at Siemens Healthineers.
Great to be here.
Wonderful. So let's get into it. There's a lot of interesting things for us to cover here today, but I would like to start with, can you give me a sense, and I'll start with Tammie, of the magnitude of the demographics and opportunity that we have here with Alzheimer's disease and disease-modifying therapies?
So there's been a lot of interest in Alzheimer's disease and radiology over the last year and a half because of the approvals for these disease-modifying therapies in the US and now several in Asia and also in the UK. So some in the UK and now in Europe was the most recent. So these therapies they're called anti-amyloid immunotherapies, and they're IV infusions that patients take that help the body to remove the amyloid pathology. So basically activates your own immune system to attack these misfolded proteins in the brain. When they're doing that, though, you can imagine an immune response directed at your brain can have some side effects. And the main thing we worry about is called amyloid-related imaging abnormality, or ARIA. And that's when that immune system is attacking the deposits in a way that causes blood vessels to have leakage that we can see as vasogenic edema on an MRI with FLAIR, and we can see as hemorrhages, usually micro hemorrhages, like a dot, sometimes macro hemorrhages, larger, sometimes superficial siderosis. So for the imaging community, we have a huge opportunity to participate in the care of these patients, both from their baseline MRI for diagnosis and eligibility, for their monitoring MRIs, and also other aspects of our field would be the lumbar puncture for CSF or the PET scans to look for the amyloid or tau pathology. Now, getting to your question, which was actually just the magnitude of it, we have big numbers. Everybody sees the big scary numbers, millions of people, billions of dollars for Alzheimer's disease. I think a more practical way to understand this is in my practice. For the first 180 patients that started the therapy, we generated 1,000 additional brain MRI visits. We anticipate wanting to treat, ideally, in our region, because I'm in Missouri and we basically are the main academic center for a 300-mile radius, we would love to be able to treat maybe 10 or 15,000 patients. So the number of brain MRIs that I need to build up capacity for is incredible. And so how do you deliver this service in a way that gives a quality exam for your patients in a timely report and doesn't generate something that's either time-consuming to acquire, unreliable, or takes too long to interpret? So a lot of challenges in workflow for the
I love that. Let me just give you a chance to catch your breath. And Saurabh, you're on the MR side. Based on the size of that opportunity, what can the MR manufacturers do to make this exam more reproducible, more patient-centered?
Yeah, it's a great question, and thank you, Tammie, for setting the stage, right? I mean, we have so many patients that suffer from Alzheimer's disease, right? There's 6.7 million Americans that suffer from it today, and so the number is expected to double to 13 million by 2050, right? So that underscores the need for early detection and treatment, and thankfully now we have these treatments, right? So when we think of this, right, our role is enabling providers like Tammie and everybody else, and we're focused on two things. It's making scans faster and making the workflow reproducible so that we can get consistent, fast scans every time. Because as Tammie mentioned, one of the things that's needed is a longitudinal analysis of ARIA over a period of time. So it's important that scans are consistent and fast. And the way we're doing it is leveraging a lot of artificial intelligence. So we're using tools such as automated patient positioning, automated brain slice positioning to make sure there's reproducibility. And then of course on the fast scan side, we're using a lot of our deep learning reconstruction technology to make them faster.
No, I love those points, and I would echo everyone. But have you done anything to make sure that the field have the appropriate protocols on their machines when they go to battle? Because unfortunately, experience has dictated that left to our own devices, we really won't get it quite right. And sometimes you can make a critical error that will substantially affect sensitivity. Has Siemens or any of the other manufacturers you're aware of done anything to make that less variable?
So again, great point, great question.
I thought of this in advance, so I was ready.
So we have, and interestingly, we have actually worked with Tammie on this, and like a lot of folks from the ASNR's committee that works on dementia, and not only Siemens, other manufacturers also. We have developed protocols. You could download these ASNR recommended audio protocols from our website or from ASNR's website. I think the key, and looking into the future, the obligation for all of us here is to make sure that there's more awareness of these, that the fact that these protocols exist, and there's more education so that everybody can make use of these protocols.
I think that's great, and I think it really is best for patients and best for your constituents who are your customers. So you mentioned a really impressive number. It looked like somewhere 8 times, 7 times per patient. Can you just review for a moment what the standard recommendation is? You've got a screening exam and 4 to 5 over the next 6 months. Can you just review that for us?
Yeah, that's about right. So in order to be eligible for therapy, the patients need to have a screening MRI or baseline MRI, and you need to make sure that they don't have signs of CAA or cerebral amyloid angiopathy. So if they have a lot of microhemorrhages on that baseline MRI, they probably have a lot of vascular amyloid, and that puts them at more risk for these side effects. You also have to look at it as a diagnostic neuroradiologist and help understand, is their cognitive impairment consistent with Alzheimer's based on the imaging? So if you see there are multiple infarcts, or there's a brain tumor, or they've had head trauma, craniotomy, all the things that we normally do in a report are critical for these patients, because if their impairment is related to these other things, they're not going to respond to an amyloid immunotherapy, and in fact they might have worse side effects from it. So there's that baseline MRI, and a certain percentage of these patients will screen fail based on that. So they'll come in specifically to get the drug and come into the clinic and then not pass that MRI step.
Do you have a sense of how many, in your experience, will screen fail?
So in our network, I would say about half of the patients presenting with dementia are ending up going on therapy. So sometimes it's because of the MRI, sometimes it's because they don't pass the amyloid testing component that's required. Sometimes it might be a comorbid condition, so they're getting cancer chemotherapy for something else and they don't want to give 2 different immunotherapies or chemo at the same time. Or it might be that their dementia is too far advanced. So there are a number of reasons they can screen fail, but they all have to get the MRI in that process. So that's part of that increased volume. And then the other part is, once they go on therapy, for the 2 drugs in the United States right now, which are lecanemab and donanemab, each has a slightly different schedule in the label of the MRIs that are prescribed. But yes, it's about 4 or 5 MRIs in that first 6 months. And the MRIs come in 2 types. One is on a schedule on the label. So before infusion X, Y, or Z, you're going to get an MRI. And if it's okay, you can get the infusion. They also, though, have the other triggers. So if they have symptoms, and the symptoms can be pretty nonspecific, increasing confusion, headache, dysarthria, wandering, abnormal gait, all kinds of not very specific symptoms, they have to get another brain MRI. And if you found ARIA on a brain MRI, it triggers monthly brain MRIs until the ARIA resolves. So yeah, we're finding it's more like 7 or 8 on average that you're getting in that first 6 months. And you need to be able to have the capacity not only to schedule them and do them on the schedule that's prescribed, but also to modify the schedule based on symptoms and have a quick way for them to be able to come in and get an MRI if they're having the symptoms, and avoid sending them to the ER, down a stroke workup, or other pathways.
Now, do you find some of the things that you heard Saurabh describe make it a little bit easier and more effective to compare between exams? Because that would seem to be a real challenge.
Yeah. So, one of the biggest challenges has been around this issue of the microhemorrhages. So, as radiologists, we're all very familiar with the fact that these are tiny findings and they're highly impacted by the sequence that you run and the field strength. And up until this project, I'm not aware of any large-scale standardizations between vendors and platforms that had been done. So what Saurabh was describing was the work that was done through the American Society for Neuroradiology and the study group for Alzheimer's, ARIA, and dementia, which collaborated really closely in partnership with Siemens and GE and Philips. And we had different working groups at different sites running test protocols across real patients to identify, making sure that the same minute microhemorrhage findings could be seen between the SWI and the GRE T2 star and could be seen between the 3T and the 1.5T, and that if you hopped between Siemens and GE, you'd get something as close as possible to being the same. And so that was so much fun to be able to do that project together. We were having monthly meetings and reviewing cases all the time, and an incredible commitment to patient care to put that together. But the protocols that came out are about 10 minutes long. So easy to run, so easy to install, so easy to read, because you don't have to look at 1,000 other images as well. So I'm just really, really proud of that, and I hope that people watching this will go and find the protocols and use them.
I mean, that's great. As you know, I was responsible for a large enterprise, and getting the protocols consistent and appropriate is much more challenging than you'd expect. It can be really, really difficult and very discouraging. I had a lot of pride in the quality of my network that I created, and it was a humbling experience to see things that continue to pop up.
Yeah.
So I have a couple of questions here that I think might be really of interest to the folks who are listening that don't have the experience that you have in inside an institution. So, a couple of things. Are you doing genetic screening?
We are now. So the genetic screening for Alzheimer's is the ApoE genotyping. And if you have 2 copies of the ApoE4 allele, you're at the highest risk for the vascular amyloid deposits, which are related to ARIA. But even just 1 copy, so if you're an E4 homozygote versus heterozygote, even just 1 copy can make an impact. The ApoE screening guides that risk discussion that the neurologist has with the patient. It's not an absolute contraindication, at least on the FDA label and at our institution it's not. Some institutions are actually right now not treating patients who are ApoE4 homozygotes. At the start of therapy, we were having trouble with insurance paying for the ApoE genotyping, and we had a number of patients who started therapy who said, you know what, all this is going to do is change my risk. I want the medication anyway, and so we're missing it on a number of our early patients. More recently, we're finding insurance is paying for it, and so we are getting that.
Oh, I think that's great. It's really nice to know that insurance is paying for the genetic screening, and I think we all know that there really isn't an issue getting the MRs paid for, because they're billed as part of routine practice. I have a question for you, and I'm not sure you've been asked this beforehand. In your patients that are 4/4, both alleles, how often, and presenting with cognitive impairment, how often do you not see amyloid angiopathy?
Well, so here's the thing. If you look at the literature around this, the microhemorrhages associated with CAA are most commonly seen once patients have a diagnosis of dementia. So if you were to do the clinical dementia rating scale, it would be CDR1 or higher. The patients who are going on therapy are typically CDR 0.5 or even CDR 0, but a diagnosis of MCI or mild cognitive impairment. And in that diagnostic range, microhemorrhages are not that common. So we're not actually finding, at least in our institutional experience, a high correlation between the baseline microhemorrhages and the ApoE4 status in this very early group, but that doesn't surprise me.
Nice. So I have another question. Since positron emission tomography PET is important to the diagnosis, sometimes even to the surveillance of these patients, either seeing whether therapy is working or potentially ceasing therapy, right? And all of these patients get MR scans. What do you think about an MR PET, the role of an MR PET in this circumstance? It seems to me this may very well be the first killer app outside of certain oncologic implications. What do you think?
Absolutely. One of the things I've come to understand in the course of this therapy is how much we're asking from patients and their families. So that all of the testing that we're doing up front, and then the monitoring and the infusions, and if you're somebody with mild impairment or early dementia, you're not coming alone, right? Someone's coming with you.
Absolutely.
And you're making multiple trips to the medical center. And what does that translate to? Well, that translates to patients who maybe can't get therapy because they literally, an extra half day or a day of asking their daughter to take off work means the difference between being able to start the therapy or not. So MR PET is perfect for this application. You're going to get both of these answers at the same time. And if you're doing it at that baseline, then when the patient comes in for that evaluation with the neurologist, they clearly know, do they have amyloid positivity or not? And what other brain pathologies are there on this MRI to explain their impairment? They can actually do a comprehensive assessment and reporting. So I think it's incredibly valuable.
Seems like a value, and it's a very patient-centered move, I would think, and I think you described that very eloquently. We have a little bit of time left. Can you talk to me about some of the challenges we're seeing in reporting?
Yes, reporting. So, with any new therapy rollout, there are things you don't expect to see. So there are things you anticipate and you fix. So the protocols, we anticipated it, we fixed it, we've got a good handle on how to handle that. The reporting has been interesting, and I think the part of the care I hadn't understood as well before this is how important the mid-level providers are. So in these clinics, the nurse practitioners, the physician assistants, they're the ones taking all the patient phone calls, ordering the scans, calling the infusion center to go, no go. I mean, they're really managing everything with that. We need to give them a structured report that spells out very clearly what the findings are on the exam. So on the radiologist side, radiologists aren't missing the findings, right? We know how to see vasogenic edema, and if you tell us to count the microbleeds, we'll do it. But we're not always communicating that in a way that's helpful. So what I've been seeing come through that's causing confusion is I've had radiologists say, oh, I didn't call it severe because I thought that was clinical. So a misconception that in this case, mild, moderate, or severe for ARIA refers to the imaging finding. And so if you say that there's edema and don't say that it's moderate ARIA-E, what you have to understand is, yeah, maybe if it were an attending neurologist reading your report, they would figure that out. But if it's the PA, you need to make it clear so that they can act on it in a timely fashion. Other thing is with the microhemorrhages. We'll say there are 10 microhemorrhages, but we won't say if they're new or if they're old or how many there were before. So, these things are really easy for the radiologist to identify, but what we need to do is report them in a way that's consistent and coherent so that the end user on the other side, whether it's that physician assistant or the attending or the patient's family members seeing it in their MyChart, can understand what we're finding. And that's been something that I've really learned just in the last year. And I'm actually looking for advice from people like you who have experience with large networks of radiologists to better understand how can we come up with a report template that's even easier to use.
It's an interesting thing. You were quite sanguine about how well the radiologists are doing reading these exams. My experience is a little less optimistic. And I think it clearly, from my perspective, there's clearly a need for education, and there may be a need for AI assistance in the reading. Do you have any opinion on that beyond? I know you've spoken as if your radiologists aren't challenged. I've seen challenges even amongst experienced neuroradiologists Okay, what do you think about the second half of that question? Whether you need AI or whether you'd recommend any specific education?
So we've been working a lot on education. I think the main place the education, at this point, I now think the main place education will help us is in the ER setting, so that we don't accidentally put somebody down a stroke pathway and give them thrombolytics and cause a hemorrhage to get worse. I agree with you now that I have looked at a larger case experience coming out and have seen the larger pool of radiologists reading this at my institution is subtle findings, like a mild RAE is easy to miss, right? It's just one more hyperintensity on flare in a sea of hyperintensities. If you're trying to read, so for me, 6 cases an hour is a struggle. That's an easy number for most neuroradiologists, right? So if you're trying to read 10 cases an hour or something, and that's a finding on one image with longitudinal comparison, you're going to miss it. So tools that can highlight it and find it and help you score it to get that grading correctly, help you communicate it through the system correctly. These are things that AI and automation, I think, can really help us with. And I'm actually pretty excited about some of the things I've seen at RSNA today.
Well, very nice. So I have one last provocative question. One of the challenges with imaging this patient population is access. And we've heard efforts going on to attempt to use machines that are not at the 1.5 or 3T. In the Siemens camp, it might be the MR Max, which is a very comfortable, accessible magnet, easier to place. But in other words, even looking at lower field systems. And in both of those cases, there's going to be a certain amount of challenge to detect the hemorrhage. On the portable units, it's probably you need a large amount of imagination, in my humble opinion. But at 0.5, you're certainly going to have lower sensitivity. What is your opinion on whether or not you could use ARIA-E as the sole marker to indicate if you don't see ARIA-E, there's almost certainly no hemorrhage, that kind of a take? What do you think?
Yeah, so in the clinical trials, the ARIA that changed management and had symptoms and progressed was ARIA-E. And the hemorrhages that were identified that were not associated with ARIA-E, the microhemorrhages, were not, if you look at the lecanemab trial, were not different between the placebo group and the treated group, so the isolated microhemorrhages. So I think in a situation where you've got a really good relationship with the patient and you're confident that they're asymptomatic, you could feel comfortable using ultra low field to look for moderate ARIA-E, and if you don't see that and they're asymptomatic, going forward. I feel very comfortable with that, and I have a whole research project around this, so, yeah. So, and we're still trying to finalize the results, but the results I've seen so far, I'm comfortable with that. I'm also comfortable with that in the setting of certain devices or other issues where you may have to be choosing between that or a head CT. For routine surveillance, like, somebody has a high-risk pacemaker device, I'll scan them, but I'm not going to scan them every month, right? Like, I just don't have the capacity for that. So what I'm telling our clinic is, okay, well, my recommendation is we will get a good baseline with the nurse practitioner from EP, with the physicist, with the vendor, all of these things in place. But after that, if they're asymptomatic, I'm going to monitor them with CT or low field, where
That's
I feel more comfortable.
Yeah, it's all the gray areas that are really fascinating here. The formula is pretty straightforward, but what the experts do in the gray areas is really quite fascinating. And I think it's going to be an area where we'll still need to meet, we'll still need to discuss, we'll need to learn from each other to really see what the best practices are. This is fascinating.
Can I make one last comment?
You may.
On the Freemax, I know we didn't talk about this ahead of time. We didn't, and this is not a sales pitch, but we had one of those scanners for about 1.5 years, and I loved that scanner for brain MRI. And I did not find any cases where I didn't see microhemorrhages with the protocols we were running. So maybe I need to publish that.
I think
That's
you're making
amazing.
Saurabh
That's
a little,
very-
I think you're making him a little
That's great
emotional
news.
here.
Yeah, it was a workhorse.
Well, I think that does need to be published,
Yeah.
at least presented. Right?
Yeah, no, we just need to put it together because we have low field, high field scans on those guys.
Yeah, there's a project for us to work on.
Yeah.
Another project.
Well, I think this was an absolutely fascinating discussion. I think this is a good place to wrap up our discussion on preparing the enterprise for growth in Alzheimer's imaging and management. I would very much like to thank our really interesting panelists, Dr. Tammie Benzinger from the Mallinckrodt Institute of Radiology and Saurabh Sharma from Siemens Healthineers for joining me. It was an honor to participate with both of you folks in this roundtable series to discuss the latest trends in Alzheimer's imaging and management, being hosted by Applied Radiology with sponsorship from Siemens Healthineers and Agora Care. Thank you so much.
Thank you for having us.
Thanks.